me get started. Thanks for coming. So we're lucky today to have Dr. Jerry Blaivas, who is a pending professor of urology here at Mount Sinai. So Dr. Blaivas is an internationally recognized urologist with over 30 years of experience. His expertise ranges from the routine office management of lower urinary tract symptoms in men and women to the very complicated surgical procedures. In addition to his expertise in routine problems as prostate, BPH, pelvic organ prolapse, and continence, he was one of the originators of urodynamics and pioneered many of the surgical procedures to correct incontinence, urinary fistulas, urethral diverticulum, overactive bladders, and neurogenic bladders. He's actually one of the few surgeons who still routinely performs reconstructive surgery for prolapse incontinence without the use of mesh, right? And has a vast experience treating vaginal mesh complications. His particular clinical interest in complex urologic problems, complications of radiation and prostate surgery, failed prolapse surgery, and has published a large series on reconstructive surgery in women, autologous slings, bladder neck obstruction.
That's enough. That's enough.
I can't listen. One more thing. Okay. Anyways, Dr.
But thank you. So Nocturia is kind of an avocation for me, because it's, as you'll see, I don't understand why more people aren't interested in Nocturia, especially internists in primary care, because it encompasses almost the entire field of medicine. The differential diagnosis for some of these things that we treat is enormous. It's almost every disease that walks into the floor. I do have a couple of disclosures. I'm the co-founder of a medical software platform, and I will be showing you a little bit of it here, because that's how we manage, that's what we use to manage Nocturia. And I'm also a consultant to a brand new company that's trying to, that's developed a new drug that it's just in phase 2 trials, but it's a completely different concept. It basically works on prostaglandins. I don't mention it in this talk, but it's something interesting. So Nocturia obviously is getting up. Oh, thanks for inviting me, by the way. Nocturia is getting up at night to urinate, avoiding during sleep time. There are both pathologic and non-pathologic causes of it. Pathologic, so either the bladder doesn't hold enough urine, there's something wrong with the bladder, the kidneys make too much urine, or, I'm sorry, I'm getting used to this, I think I'm used to the keyboard. Okay. The kidneys make too much urine, and or this is a disordered sleep. So there's only those three things. Bladder makes too much urine, more urine than the kidney. The bladder doesn't hold enough urine based on how much urine production there is. The kidneys make more urine than a normal bladder can hold, or there's a sleep disorder and the patient gets up to urinate afterwards. And the evaluation is very simple. The treatment is not simple. The evaluation is you just do a bladder diary, and then of course that you can expand on it with the history, but you do a bladder diary and then you do the math based on the bladder diary. And I'll go through that in a little bit more detail. Nocturia is very common. You can see here by age 80, 80 to 90% of men have Nocturia, and a slightly smaller amount of women. Nocturia of more than 2 times a night is a health risk that I'll be talking about. And again, so Nocturia increases in prevalence with age. And if you look at the 2, 3, and 4 voids a night, so for example, by age, approximately by about age 50, the prevalence is up to 30, 40, 50%. And in those people, we believe that just getting up at night, especially in younger people, to urinate may be a health risk. There's not good data on this that you'll see in a few minutes. There is good data on mortality, but I'll show you that in just a minute. That impairment of quality of life is significant. In this graph, this was a study of thousands of patients in Finland, and in this graph, these are different aspects of quality of life: moving, hearing, seeing, breathing, sleeping, eating, etc. And one is normal, one is no symptoms, and these increasing numbers for both, or decreasing numbers for both men and women are related to the number of times that you void at night. So if you get up once at night, just for example, you can see over here, there's a mild impairment of quality of life with respect, well, that's sleeping, which is take something like speech. There's a very mild impairment of speech in patients with getting up once at night, but with getting up twice at night, sorry, I lost my, there it is. Getting up twice at night gets worse, and getting up 3 or more times at night, it gets even worse. So in every single domain of quality of life that was measured, the more times that you get up at night to urinate, the worse the impairment. Now, of course, you could get up at night, it would be the same impairment whether you urinated or not. But in fact, almost everybody that gets up in the middle of the night urinates no matter what. I mean, not exactly sure. I think maybe just I better urinate before I go back to sleep. So the nocturia and sleep interruption are very common, very commonly coordinated with one another. So nocturia causes symptoms and impairs health by interfering with deep sleep. Deep sleep is slow wave sleep, and it's basically stages 3 and 4 of the sleep cycle. I'm not going into much of the detail. It occurs early in the sleep cycle. Most of it, more than about 75% in the first 3 hours of sleep. And this is the deep restorative sleep that's necessary for overall homeostasis. There's about a 75% drop in cerebral metabolic rate and in blood flow during sleep. It's thought, I mean, it's been shown, again, I'm not expert at evaluating these studies, but it has been shown, and you can look at the studies if you care to, that it prevents neuronal damage by destroying free radicals, which cause oxidative stress. And if someone is awakened during during deep sleep, you're groggy and confused. It's also been shown to be important to dependent memory processing, to declarative or fact-based memory, glucose metabolism, and secretion of growth hormone. This was a study. This study was done by a urologist to simply compare to determine when you're first awakened in sleep by nocturia. And what they found is that the yellow here are the deep sleep phases, and this is just one. This is one patient, but in this particular patient, and this was the average, they awakened in less than 2 hours, about an hour and 3/4. So they interfered with almost half of their deep sleep. And again, it's believed that it's this interference with deep sleep that causes all of the symptoms we'll be talking about. So what are the consequences of nocturia? Daytime sleepiness, impaired cognition, mood disturbances, depression, increased rates of sick leave, of auto accidents, occupational accidents, falls and fractures, and an impact on general health and mortality. Now, for most of these things, my review of the literature, they're not very well documented. I had a whole bunch of slides that I decided to delete because it was boring to me. So I can only imagine what it would have been to you if I went through them, that show individual studies that document all these things. But the studies, to my eye, are not very well done and not terribly convincing, but they do make sense. And some of the stuff I think you'll see the mortality is well documented, and that was a total shock to me, and that's mostly why I became interested in it. I said this couldn't be, and I'll show you that in just a minute. So the most important effects on general health include memory, cognition, diabetes, hypertension, metabolic syndrome, and mortality. And there is some evidence in the literature to support all of that stuff. And I'll leave it to you who deal with those things more than I do to see how accurate those studies are. It's been shown that slow wave sleep or deep sleep is important for glucose homeostasis, and that suppression of the sleep in rats, I think, reduce glucose tolerance, and it's thought that it may contribute to an increased risk of type 2 diabetes. And this is a slide that I found particularly interesting and a bit disturbing. The effect of 2 or more times nocturia on general health in younger people. So in people aged 40 to 59, if you get up 2 or more times at night, your unadjusted health hazard ratio is, you can see these numbers, they're pretty significant. But this is the one that really struck me. A third, and even after adjusting for it, that didn't go away. And this has been shown in many good studies, I think. I think the mortality data, and I'll show you that in a minute, is the only data that is very convincing to me. And interestingly, there didn't seem to be much effect at older age. I don't have any explanation for that, but to me, the take-home message from that is, I'm sorry, I was looking at my watch, I didn't realize you had a clock back there, because it kept going off. See where it was. I don't know why in older people that hazard ratio went away, but to me it's pretty scary that about the mortality for younger people getting up twice at night. And here's just one study that this was quite a large number of patients. It was a population-based study, and I thought it was done pretty well. It's highly significant, and basically, this is the curve. This is people with less than 2 times a night nocturia, and this is with nocturia. And again, for younger, most of the mortality data, the increased mortality data was in younger people, but overall, I mean, it was quite significant. And there have been many studies. Many studies have documented the same thing, and most of these studies have large numbers of patients. Some in the tens of thousands, and in every single one, except for this one, there was a considerable increased risk of mortality getting up 2 or more times at night. Now let's talk about the etiology, the causes of nocturia. As I mentioned, there are pathologic and non-pathologic causes. The kidneys make more urine than the bladder can hold. The bladder doesn't hold enough, or there's a sleep disorder. The patient is awakened by something else and then voids for reasons that we don't know. So that's a simple way of thinking about it, but that's the way it is. And so I'm going to tell you how I evaluate nocturia, and this is the way and I'm going to discuss a little bit of what I consider to be a new paradigm of healthcare in general, and that does involve that software that I was telling you about that I developed, and that's in a sense, it is a conflict of interest, but I need to tell you that I developed that not as a company or a business. I developed it as an NIH grant, which I submitted in the year 2000, 18 years ago. They politely laughed at me. They didn't give me a score, okay? And they basically said, this is ludicrous, okay? And what it basically does is it makes the patient, this is not part of my talk, but I get passionate about this. It makes the patient the one that records his own symptoms. So instead of you asking him a bunch of questions, the patient fills out questionnaires. Okay, they are scored, and they're quantitated, digitized, quantitated, and scored. And I'll show you in a minute. And you see the scores. And then I'll show you how I use it in just a minute. But the basic, most important part of the Nocturia evaluation is to do the questionnaire and the diary, okay, and then do the math. And the do the math was, I love that phrase. It was an editorial that a good friend of mine wrote, co-author of the only book on Nocturia. And he said, do the math. The treatment, the diagnosis and treatment of Nocturia is doing, in my judgment, is doing a bladder diary, do the math, and then understand the differential diagnosis that causes the underlying problem. That's what I'm going to be talking about. And of course, we throw in there a history and a urinalysis, and for urologists, a uroflow and a residual urine, I think is very important, but most of my peers do not. So here's the results of using the software. Patients fill this out on an app. Okay, it's a 14-question questionnaire that deals with all of lower urinary tract symptoms, and the questionnaire has been psychometrically validated and published. And so the score is a total score and then 6 subscores. Okay, and the total score goes from 0. So in the symptoms, I'll go back. The subscores are total score, voiding symptoms, difficulties urinating, storage symptoms, difficulties holding urine, overactive bladder, frequency, urgency, having to rush to the bathroom, incontinence, nocturia, which is what we're talking about here, and how bothersome it is. So now here's the new paradigm. A patient calls my office, and they say, they'd like to make an appointment, or they get on a website or something. And they say, well, do you have a lower urinary tract? Any symptoms will ask them. If they say yes, we said, well, before you come, we would like you to download the app and do a questionnaire and a diary. Okay? And then we're going to see that before you make your appointment. They make the appointment, and now here's a patient that the blue is before we saw them. Okay? And we said, well, and then they had a lot of bother. And, and all the symptoms, the green is no symptoms, or normal symptoms. The red is the worst possible symptoms. And the orange is medium symptoms, if you will. So this person had a lot of bother on this date. Okay? And the symptoms were kind of, in the middle, not the worst symptoms ever. So we said, well, what's bothering you? And the patient said, Nocturia. We've done a lot of research on this, and symptom severity has a very imperfect correlation with bother. So people can have, like, for example, the worst of it is there people with fecal incontinence. Okay? Most people with fecal incontinence have incontinence 2-3 times a year. Okay, and their bother is right at the top. And they have all these other symptoms, but what bothers them the most is fecal incontinence. And so it's a really good tool to be able to understand symptom severity, which this is. So in this particular patient, the worst symptom severity was overactive bladder, frequency, urgency, etc. But what bothered her the most was the nocturia. And so I'm thinking that this is a nocturia patient, and I haven't seen her yet, and I'm going to go back to this in a few minutes when we talk about the diary. Okay, there's the diary. The diary they keep for 24 hours. Every time they urinate into a cup, and then they measure the amount that comes out, and they answer some questions about it. I'm not going to bore you with all the questions, but the two that relate to nocturia are, obviously, did you wake up from sleep and urinate? And the answers could be no. Yes, I was awakened by the urge to urinate. You'll see in a minute, we call that a non-urgency nocturia void. So they're awakened it's a nocturia void. I was awakened by something else, but, oh, I'm sorry, this is a nocturia void, I got ahead of myself. I was awakened by something else that's a kind of a non-nocturia void, or a sleep disorder void, or I can't tell the difference. And the second question they ask about when they do the diary is, why did you just urinate? This is something that is called the urge perception score. And all of this stuff has been psychometrically validated, published, and we use it. If they say they just urinated, if they had a mild urge, they woke up and they said, well, I'm going to go back to sleep, so I'll just urinate. That would be mild urge. I have a moderate urge, but I know I can wait at least an hour. Okay, or we call those nocturia non-urgency voids. If they say that that when they urinated they could only delay for 10 minutes or had a desperate urge and had to rush, we call that an urgency void, a nocturia urgency void. So in this published study, we found that the great majority of patients that have nocturia have non-urgency voids, that these men and women in here, but about 10%, it appears that the nocturia has nothing to do with the bladder at all. It's a disordered sleep or some other reason. And it's important to know these things because the treatments are obviously vastly different. So now we have to do the math. Okay? Before I show you the diary, there's two. The software does all the math, but if you can look at you can literally look at the diary and do it yourself. So there's two parameters that we look at: the Nocturia Index and the Nocturnal Polyuria Index. The Nocturia Index is simply the nocturnal urinary volume overnight, how much urine you make overnight, and over your maximum voided volume. So, for example, if you make 600 milliliters overnight, and your maximum voided volume is 325, your Nocturia Index is 1.8, and nocturia occurs because bladder capacity is exceeded, and then the predicted number of nighttime voids would be this number minus 1, because if you can hold your bladder, if you can hold 325 millimeters, you get up once at night to urinate, but then the neck you only put out another 8/10 of what you could hold, so you should be able to only get up once. The second important parameter is the Nocturnal Polyuria Index, and the simple one we use is just the nocturnal volume divided by 24 hours, but divided by 24, assuming that you sleep 8 hours. It's not rooted in science. None of these numbers are rooted in science to my satisfaction, but nevertheless, they're useful. So here's the bladder diary summary on this patient. Now I'm going to just quickly tell you what I do when I see the patient. So, actually, before we see this patient, we would look at this and we say, wow, this poor person voids a lot, okay? This is almost polyuria. They voided 15 times, 4 times at night, 4 urgency voids, 324 milliliters she could hold, and her nocturnal polyuria index was 0.5. She puts out half of her urine at night, and that's what bothered her the most. So now this lady we ended up seeing, but most of the time we take a person like this, we just quickly speak to them on the phone and say, look, you put out half your urine at night, you get some kind of a little history, and just make sure they're not out of control of diabetes. If they're already in your EMR, then it's easy to check whether they have any of the underlying causes, which we'll talk about in a few minutes. And then if they do, you can check your diabetes. So this is all you do before you come in. So in this lady, we just told her to make it simple. Just cut back on how much you drink. So she went from almost basically 2,500 milliliters to to 1,400 milliliters, from 15 voids to 7, from 4 urgency episodes to none, and from 0.5 Nocturnal Polyuria Index, NPI, to 0.9. So from a symptomatic standpoint, you can cure this patient without ever seeing her. Okay? And there are economic, and the beauty of this is it's good for the patient and the doctor. The patient can see all this stuff through the website. She can see exactly that. This is part of what we call our one-page summary. So she can see that, and the doctor can see it. And again, I believe it's going to be a new way that we patients with every single, what I call symptom-driven condition. So, pregnancy is one big symptom-driven condition, okay? And I'm serious, okay? Irritable bowel, for practical purposes, pain syndromes, psychiatric conditions, they're all symptom-driven conditions that if you can quantitate the symptom and present it in a quantitative way, that graph that I showed you, then both you as a physician and the patient can begin to get a much better understanding. And then if you look at it over time, you can see how they're doing. And that's why I'm so passionate about it. So based on all this, we developed a whole classification system, phenotype system for Nocturia. And we divided Nocturia into these 5 phenotypes. Polyuria, they make too much urine. Nocturnal polyuria, they make too much urine at night. Small bladder capacity, bladder doesn't hold enough. And a mismatch, which is very common. These are this is a study that we haven't published yet, but this is our current data. And so a mismatch means that their bladder holds a normal amount and their kidneys put out a normal amount per day, but because of the wide variability of normal, when you can make a liter a day and have a bladder capacity, I'd say you make this up, a liter, say you make 500 cc's overnight, which would be normal, and your bladder holds 151 milliliters, which is normal. They're both normal, but there's a mismatch. You have to get up 4 times a night, 3 or 4 times a night, because your normal bladder can't hold enough to deal with the normal amount that your kidneys put out. So now we'll just talk a little bit about polyuria. I mean, obviously, the more you drink, for almost everybody, the more you drink, the more you urinate. And so the causes, there aren't very many. The overwhelming thing that we see is people just think it's healthy to drink a lot, so they drink a lot. No place worse than Manhattan. I don't know how the public toilets survive in Manhattan. You hardly see a person walking around without a water bottle. So I call that an acquired behavior, or for me, for people that have bladder problems, it's just a bad habit. Uncontrolled diabetes insipidus, I've yet to see one. I mean, I've been doing this a long time, but no one ever came in my office with diabetes insipidus complaining of Nocturia. And then primary polydipsia, which is thought to be a sort of a psychiatric compulsive water drinking. But overwhelmingly, in a urologist is going to see acquired behavior. I don't know how often primary care doctors will see the other things in this differential diagnosis. The treatment is simply to reduce the water intake in patients without DI, because if you do that, if they have DI, they can become dehydrated. Treat the underlying conditions, the most common acquired behavior, break the habit, and if everybody drank 8 glasses a day, everybody would have polyuria. And that's the truth, because if you do the math, a steak, which I think has one of the lowest concentrations of water, is 60% water. So if you drink 8 glasses a day, that's almost 2 liters a day. And if you have, 1 steak, you're over the 2,500 limit. Diabetes, obviously, you have to manage it, and central diabetes insipidus is antidiuretic treatment. Nocturnal polyuria, we'll talk about that. The etiology, this is where it gets really interesting, I think, for me, and I think for internists, primary care doctors, because there's such an enormous differential diagnosis. So if a person makes an excessive amount of urine at night, again, for urologists, probably the most common cause is, again, excessive drinking before they go to bed. A couple of beers will do it for just about anybody. But the differential diagnosis of just pick some peripheral edema in particular, looking for obstructive sleep apnea, heart failure, medications. It's on the list. I don't know how to evaluate that. That's my good Jeff Weiss, who's I think the guru in the world on Nocturia, gave me that stuff on medications. I've never seen it. So how do we treat nocturnal polyuria? Well, first we look for and treat remediable conditions, and if we can't find any, we try to empirically decrease urine output overnight. The most remediable condition is just to decrease the fluid intake before bedtime, and then of course optimize treatment of obstructive sleep apnea, diabetes, congestive heart failure, peripheral edema. And I don't know whether you guys and the primary and internists, cardiologists treat these conditions well enough so that I don't see very much. I hardly ever see nocturia that's caused by one of these remediable conditions, because everybody seems to be either treated well enough, or maybe they have nocturia and aren't bothered enough to see anybody about it. Empiric decreases of urine output, compressive stockings, repeated edema, raising the legs, taking a nap in the afternoon. So far as I can see, this almost never works. But everybody does it. Time diuretics, giving a short-acting diuretic like furosemide about 6 hours before bedtime, with the idea of getting rid of the fluid before you go to sleep. I've done a lot of that, and I've had some fantastic successes, but not that many. We need a lot more interest in this, a lot more research into finding better treatments. And then finally are the antidiuretics. I'll talk about that in a little bit. The antidiuretics work reasonably well at decreasing nocturnal output. They don't work as well in treating the nocturia, in my opinion, because people develop habits. So even though the nighttime urine production goes down, you may persist with the habit and still get up anyway. So I'll go through the data. So I assume I won't bother with the pathophysiology, but the bottom line is obstructive sleep apnea is a major cause of nocturnal polyuria. Like I said before about the literature is just a paucity of literature on effective treatment. None of these these 3 studies that I'm showing, none of them even had controls. This is just, they gave a bunch of patients, they treated people with sleep apnea, and this is what happened. And in each of these 3 studies, the pre-treatment nocturnal episodes, 3.8, 2.5, 3, and they went to 0.7, 0.7, and 0. That's as good as any treatment in the literature. But again, there's only very, very few studies. I don't know how well it's going to be shown to how effective it's going to be in the future. But of course, sleep apnea has its whole range of other risk factors and other things that it causes, so it needs to be treated. Time diuretics, very modest. It mirrors my experience. Pre to post was 3.4, 2.9. And then, of course, you'll see this with anybody that's trying to make a point. They always develop new metrics to make whatever they're doing look good. So, decreased by 2 voids, 21%. I don't know what you tell a patient. They come in if you can decrease, 21% chance of decreasing by 2 voids. I just don't know how that's helpful. But that's what we do. That's what we tell them. We say, let me try this, we do this. All of the treatments are just empiric, but they're empiric based on a clear understanding of the underlying physiology, pathophysiology. We just don't have good treatments for them yet. So antidiuretics are the only thing that predictably lowers nocturnal urine volume. And so they decrease urine production. It's a proven benefit that studies do show for diabetes, insipidus, for nocturnal enuresis, kids, for nocturnal polyuria, there's a spelling mistake there, and for these, and I believe for these mismatches that I told you about in just a moment ago. So there's only two available drugs that the FDA approved. They've both approved within the last year, and they're both basically desmopressin acetate, and one is intranasal. I'll show you in a minute. One is a sublingual pill. So the two are Nocturna Melt, which is a sublingual administration, and Noctiva. This company, Venus, has been trying to get this approved in the United States. I'm not exaggerating, for as long as I have been in urology. That's how long they've been trying to get it approved. And it was just approved in March of this year. The second drug, I saw these poor guys had to wait 30, 40 years to get it approved. These guys got it approved on their first try, and they got it approved first, and it's the same drug. The difference is how they investigated and dealt with the major problem, the major side effect, the major concern that I have, and that's about hyponatremia. Okay, just take my word for it. These drugs do decrease effectively in a dose-related way the number of nighttime boys, the number of nocturia, and they do importantly increase the time of uninterrupted sleep. So basically, that means they increase the deep sleep phase, and we don't know that that's what's really important for your overall general health. But it comes at an expense, and you can see at the higher doses, and these are doses that people got. There was over 10%. This is 12 out of 146, but almost 10% incidence of hyponatremia. I have personally had patients before I used to use this off-label. I had healthy patients end up in an ICU more than once, and it's all they're going to do is have a bunch of beers, go out with the boys, have some beer, take the pill at the time it was a pill, take the pill, and you go into heart failure. That's how powerful these drugs are. So what we have to mitigate the hyponatremia risk, if you're going to use it, you start with, I recommend you start with half the dose in people, and half of the dose in patients at risk for hyponatremia, particularly people over the age of 65. Check the serum sodium before you give it, at 1 week, at a month, and then periodically thereafter, depending upon their risk factors. Warn about excessive fluid intake prior to bedtime. And what's interesting, I didn't see that in the FDA warning that came out, but it only makes sense. And this next one is, no matter what, if you do have too many drinks, or if you drink, don't take the dose that night. Women are more sensitive than men to desmopressin. So in the Noctiva drug, the recommended dose is half of that for men, 25 versus 50 micrograms. And so that's for nocturnal polyuria. For small bladder capacity, small bladder capacity is a urologic problem that we deal with, but urethral obstruction, BPH, pelvic floor prolapse, overactive bladder, a whole list of things. But if that's the problem, I think it's best just seen by a urologist. And then I don't mean to bore you with this stuff. I'm not bored yet. I don't know. I was very bored last night when I went over this. So these are our phenotypes, but they get expanded when we, this is our 5 major ones. This is when we add the bladder capacity, and this is when we add uroflow and residual urine, and this is without, you don't even try to read it, I'm just trying to make a point, that this is, we're talking about phenotyping, taking individual patients, taking you and saying this is your problem, taking all this stuff together, then adding in diabetes and heart failure and all this other stuff. So the point of this slide is to give you an idea of the complexity and the interest it ought to generate in people other than me and Jeff Weiss. I think I'm going to end some more time for questions with what I think the treatment pathway should be. This has not been published, and this is just my own personal opinion. So you start up here with an evaluation, and again, the history for me begins with the questionnaire and the diary, and then I think, and then if you do that, and you immediately recognize the people that have polyuria, they don't even need a workup unless you think they need a workup for polyuria. Okay, so if you do that first, 10% of the patients you won't even have to see, or if you do see them, it'll be very simple. This don't even have to see. This isn't like a favor to us, so we have to do less work. If you're the patient, if you actually have a job, you don't want to take a half day off from work for someone to tell you drink less. And that's really the way it is. So you start with that, and then you treat the obvious remedial conditions. You have the cystitis, you get up at night to urinate. Severe obstruction, I won't go through that. And then you divide it into those 5 phenotypes that we discussed. For people with polyuria, you see if you find, you rule out the remediable conditions that we just discussed, and then you have them. Once you rule them out and you'll treat them, then it's just reducing fluid output. Nocturnal polyuria, again, for us is the most troublesome because it has such a wide differential diagnosis, which you have to go into and see if you can find a remediable condition and treat the underlying condition. And if not, then if you can't find it, then you late afternoon diuretics, elevate the legs, all that other stuff, and ADH or DDAVP, synthetic DDAVP. For low bladder capacity, as I said, that's a urologic diagnosis that I won't bore you with, but we look for remediable conditions like UTIs and prostatic obstruction and overactive bladder. It's not even clear that, for example, that treating men with BPH with a TERP will, the data is not convincing that it helps with nocturia. In my personal experience, it does, but also in my personal experience, I've seen a ton of patients who underwent TERP because of nocturia, who were found to have nocturnal polyuria and never needed the TERP in the first place. And then finally, sleep disorders, really difficult to treat. Sleep disorders and nocturnal polyuria are by far the most difficult things to sleep. So I work with a couple of neurologists who are really interested in sleep disorders, and between putting our heads together, I don't think we help anybody. So this whole field is just ripe for getting someone interested in it that has an expertise that is far better than mine. So if any of you guys want to work on this, I'd be happy to put my 2 cents in. I'll stop there and see if there's any questions. Or I can keep talking. Yeah.
What's the difference between this DDAVP and the one that we use for kids?
It's the same. It's simply the route of administration. And so the 2 ones, these are intranasal and sublingual. I'm sorry?
Oh, yeah, so it's just a difference in the
Yeah.
When trying to quantify the total urine volume, did you find out people can kind of like do easily? Like, do they have the easy to get the necessary equipment, or you tell them to estimate something?
I tell them just the easiest thing is just take a measuring cup from the kitchen. So we do have I tell them urine is sterile. Yeah, no, and we actually, we do give them instructions. There's a measuring cup that you can buy on Amazon. I have no affiliation or economic interest in it, but there's one that's just shaped well, that works well for men and women. Okay? You can buy it, it's about $10 or something. You do that, or I tell them if it's a busy person, look, this isn't rocket science here. Get a bunch of disposable coffee cups, measure with your measuring cup in the kitchen how much it holds, and just tell us a cup, a half a cup. Okay, we'll convert the software converts them so they can record your urine output in milliliters or cups or ounces, whatever they want, and it converts it to whatever we want. Yep.
Yeah, I'm just curious about sort of the clinical decision-making aspect of this. So I take care of a lot of older patients, and I often am thinking about avoiding treatments that have risk. So I'm wondering, Nocturia seems so common in older patients. So I'm curious about when what kind of patient prompts you consider either surgery in the case of the TURP or medication, which has the risk of landing you in the ICU. But when do you make that decision that this is serious enough that I'm going to recommend?
I mean, it's based on for every decision I make in the patient, the two aspects are bother and the severity of the underlying condition. So obviously, a person that has no bother, and a lot of people have, I mean, I showed you, I don't know how if I emphasized this, a clear correlation between bother and the number of times you get up at night. But there are people that get up at 5, I think it's driven by how easily you fall back asleep. So there's people with severe nocturia and no bother. All we do with them, I mean, if they don't have nocturnal polyuria, I wouldn't work them up at all. If they have nocturnal polyuria, I think it makes sense to look for the potentially serious underlying conditions that you probably already do as part of your practice. And you got to make sure they don't have diabetes. You got to make sure they don't have a brain tumor. I mean, a lot of the stuff is just done, right in the office. This healthy guy, no diabetes, we're done. But or woman. So if they're not bothered and they don't have nocturnal polyuria or a small capacity bladder, I would say those are the things that alert me that those things need to be checked out just to make sure that the low capacity bladder isn't severe obstruction or bladder cancer or something like that. Once no bother and no serious underlying condition, no treatment, and it's always the patient's judgment. The vast majority of people with nocturia, in my experience, don't want treatment. They don't think, and now then the problem is, what do you do with the young person that has that significant increased mortality? A 40-year-old that gets up twice at night. I mean, he may not even mention it. You may find it out some other way. We may see him because of a voiding dysfunction issue. Those people, I mean, I think for sure, at the very least, you want to make sure they don't have nocturnal polyuria, and you want to make sure they don't have diabetes, or incipient heart disease, or something. I don't know how you do those things, but do you?
Yes. We do.